So once we have a patient of DVT like this one, what were our goals? Our goal was first to recanalize and take out the clot, or lyse the clot, to prevent pulmonary embolism and to prevent thrombus propagation, to maintain the valve functions, and also to make the patient symptomatically better in future. So, like I told you, in our setting, whenever the patient actually can afford and comes in time, we tend to treat all our DVTs by pharmacomechanical approach rather than giving them anticoagulation or NOACs. And this is based on two different wonderful studies published in Lancet in 2012 and Journal of Vascular Surgery in 2012. What it said is, if you leave a residual clot, what happens is the chances of recurrent DVT is much more. And if they actually quantified it, that and the chances of post thrombotic syndrome is high. So if you have a clot burden, a residual clot burden of more than 10%, then the chances of recurrent DVT and chances of post thrombotic syndrome is higher. And if you have it less than 10%, then actually you can continue anticoagulants on this patient, and this patient will do good in the long run. So how do you achieve that in a reasonable time? You have to either mechanically take out the clot, like Dr. Kapil said, or you need to lyse them in acute care, and so that the valvular functions are maintained, the chances of VTE are reduced, and the chances of recurrent thrombosis in the vein is reduced. Also, what happens if you do this, many a times you will uncover an anatomical problem in the veins, in the proximal veins, which can lead to recurrent DVT. Anticoagulation is never enough, because what anticoagulation heparin does, it actually is not an anti-thrombotic agent, it's not a thrombolytic agent. What it does, it only prevents further propagation of clot. It sort of inhibits the clot formation side of the normal hemostasis, and it sort of uncovers or accelerates the action of tissue plasma, the normal plasminogen in the body, which actually takes care of the thrombolytic mechanism within the vein. As Dr. Kapil said, now there are various ways to actually take out this clot. He alluded on ECOS, angiojet, and trellis. Angiojet was one of our machines which we are using 15 years back, and then it was withdrawn from India, and then now it's come back. But we do not have the catheters for venous use as of now. The ECOS and trellis are not available in India, so but still we have to do a pharmacomechanical approach, and then we'll let you know how we do it. So this patient, actually, we get the patient prone. Under image guidance, it's easy, to puncture the popliteal vein. We actually, the vein is quite dilated, non-compressible, and anterior to the popliteal artery. And this is done with a micro-puncture needle. And after that, we get a sheath in, and through that, we have a catheter with multiple side holes. Or catheter for aspiration of the blood. So once we did that, we did an angiogram, and you can see the angiogram shows complete occlusion of not only the femoral vein, but also the iliac veins. And then what we did is passed in a guide wire, and post guide wire, what you see here, we did some runs of suction to the guiding catheter and the sheath. And you won't be surprised that these are the type of clots which you can retrieve if you do it in the acute setting. None of these can be achieved with anticoagulants, be it oral or be it APVIC antagonist or NOACs or low molecular weight heparin. This can only be achieved by mechanical thrombectomy. But while we are doing this, still a lot of clot is left in, and this would be an risk for new clot formation. So these patients need pharmacomechanical approach. Now, the pharmacomechanical approach comprises of three things. One is the aspiration of the clot, and trapping of the clot in two segments, and then maceration of this clot, a localized release of tissue plasminogen activator. And then once the clot is thrombolized, or the fibrinolysis has happened, you actually aspirate this. This is easily done with a trellis device, which has a vibrator, which has two balloons, proximal and distal lens, and which also has an infusion port for infusing tissue plasma activator or urokinase. And this is a simple device, but very costly, still not available in India. And how we do it is make the patient prone. As I told you, the popliteal vein would be dilated and non-compressible. You under ultrasound guided, you get a sheath in, and through the sheath, you can get a Kelly's device. But we don't use it. We just do a mechanical aspiration, and this is followed by an angiogram and giving the multiple catheter and lysing these patients. This is our result of 976 venous limbs, 976 DVTs in 911 patients. In the last 7 years, the DVT duration was 1 to 2 weeks, 1 day to 2 weeks. We did CDT in 286 limbs. We did pharmacomechanical treatment in 637. We did a mechanical aspiration in 531. We did angioplasty alone in 143 and PTN stent in 138 limbs. We had a complete resolution at the end of the treatment in 638 limbs. We just got post-thrombotic syndrome in 43 limbs out of 976 limbs. All these patients were put on oral anticoagulant therapies, except few where it was contraindicated. And we just had one pulmonary embolism, which was not major, and we had only 37 recurrence of DVT. This pharmacomechanical approach and also the venous stenting has been widely published. The best publication which I found was published in Circulation. And if you just take the way the progress in DVT treatment, in 1950s we had just anticoagulation in terms of heparin or vitamin K antagonist. In 1980 we had systemic thrombolysis. In 1990 we had catheter-directed thrombolysis, and in 2000 and subsequently we had pharmacomechanical thrombolysis. And today we have a dedicated thrombectomy devices. This is the post-thrombotic syndrome I'm talking about. This is a very bad condition, and the patients who suffer actually suffer it throughout their life. What is very important is we have to prevent this by acutely managing DVT by pharmacomechanical means rather than just putting them on oral anticoagulants or IV or subcutaneous anticoagulants. And if you see, this represents a permanent disability, the post-thrombotic syndrome, and 75% of the cost of treating DVT actually goes in managing this. Just to give you, then first, subsequently, when we had this patient treated, we also found that there was a iliac thrombosis, and we actually did a thrombolytic therapy. What we found that the patient had, stenosis on both sides in the iliac veins. We actually went there and stented that. And many times uncovering maternal syndrome is not uncommon. So any patient who comes to us has to be having pharmacomechanical treatment. Patient has to be worked for thrombophilia profile. After the treatment, we need to do an angiogram and uncover, stenosis or maternal syndrome. And if we do not find it on an angiogram, but we have a high suspicion, we must do an intravascular ultrasound. And after that, we must, if it is there, we must stent this. APVIC filters should be used with caution. And if they are used, they should be taken out as early as possible. And the whole treatment approach should be not to take out the clot in the long term, but to just take out the clot as early as possible, so that we prevent the valvular functions of the defense and we prevent post-thrombotic syndrome. Thank you very much. I'm going to be stopping here. Again, requesting you to join Dr. Philip Mohab's presentation tomorrow at 8 o'clock. He's a Nobel laureate in medicine, and he's a discoverer of nitric oxide and endothelial functions. He's going to be talking about endothelial dysfunction in cardiovascular disease and the role of the future advances which are going to happen in treating cardiovascular disease and targeting nitric oxide and endothelial functions. Thank you very much. So I would stop here and take up the questions, whatever there are. It's a very busy day. It's already more than 9:30 p.m. and we would be very happy to take some questions and find out today. So Kapil, over to you, and over to the panelists, Dr. Aarti, Dr. Monica, Dr. Pancholia.
Dr. Khanna, I have two questions to you. Dr. Pancholia here.
Yes, sir.
In the ESC guideline regarding acute massive pulmonary embolism, surgical embolectomy has been graded as class 1 level C, while the catheter directed is class 2A level C. So it is downgraded. So which one to be chosen, surgical embolectomy or to catheter?
There are two things, surgical embolectomy is not possible in most of the patients. If you can do a surgical embolectomy, it is good. But if you have no time and if the patient is very sick, in those situations, like I told you in the guideline, in the sub-analysis, patients who are, who would have required and benefited from surgical embolectomy but are too high risk for it. These are the patients who can actually go for mechanical thrombectomy and lytic treatment and as an acute setting. And this has level 1 indication in these patients of acute massive pulmonary embolism in shock and who are coding. So this is the type of patient which we discussed in the first case.
And my second question regarding venous thrombectomy, is it still validated or being outdated now?
No, venous thrombectomy is now more validated, and there are more and more publications which are actually coming in to do venous thrombectomy, and the newer devices like what I was alluding and Kapil was talking about, the ECO system, the angiojet system, they're all dedicated devices. They have the devices of future management of acute DVT, because the whole concept is if you can take out the clot and as much as clot as early as possible, not only that you prevent pulmonary embolism, but you also prevent recurrence of DVT. You also prevent the post-thrombotic syndrome and consequences of venous hypertension. So that is the in thing right now, and that is the way to go around. Do you have any suggestions here?
Yes, sir. Okay, well, definitely the pharmacomechanical thrombolysis is the way to go. That is the future, and that is going to be the treatment recommendations for the future also. Well, although the latest trial ATTRACT trial hasn't shown benefit in as compared to all post-mortem syndrome, but there was a significant improvement in patients having moderate to severe symptoms. Another trial, a Dutch CAVA trial, is about to get published about the role of ECOs, ultrasound therapy. Maybe that data will come to us very soon. That's also an RCT. But if a patient, well, we have been treating many patients with pharmacomechanical thrombolysis and catheter thrombolysis, the response is remarkable. Well, we have seen it, we have done it, and we can say that yes, definitely. But we have to select the patients correctly. Patient should be less than, normally my selection criteria is that patient should be below 55 years of age group, should have a low bleeding risk, and should have an highly femoral DVT with less than 14 days of DVT to qualify for this kind of therapies. So you have to be very, very clinically sure which patients are going to benefit, and then only go ahead with that.
So if I have to add to this, this is the standard of care at our place. Only impediment is patients who cannot afford it. The patients who can afford it, this is the way to go around. We are very happy patients in future. Most of the times we uncover Turner or obstructive lesions in the iliac confluence, and many a times we could uncover prothrombotic stage, and many times it is not protein C, protein S deficiency, but it is MPH mutation of factor V leading mutation for cysteamia. And they are quite correctable diseases, and these patients are then put appropriately on long-term anticoagulants, and they are prevented from having any subsequent disease. Dr. Arilan would actually vouch for this. I mean, we have worked together in escorts maybe 15 years or 18 years back, and that is the time when we started this DVT work. And today we are one of the leading centers in all of Southeast Asia managing these DVTs, acute massive pulmonary embolisms, and related disorders in our setting.
Dr. Khanna, I would like to congratulate you for showing two wonderful cases, one an acute pulmonary embolism and another a DVT. I have two questions for you. What is the duration of the thrombolysis you give in DVT?
Okay, that's a good question. And the duration of thrombolysis in DVT depends on three things. One, it depends on the volume of the clot. Second, it depends on the age of the clot. And third, it depends on the results which you are achieving and the lytic agent which you are using. The fresher the clot, the shorter would be the duration. The lesser the volume, the shorter would be the duration. And the third thing, if you are using clot selective agents, which are urokinase or tissue plasminogen activator, and you are giving directly into the clot, it is catheter directed. Then the duration usually is 24 to 48 hours. But if you are using drugs like streptokinase, which is not clot fibrin selective, these would have more bleeding. They have to be given in higher doses for a longer time. And the results are not as good as these two agents, the clot selective agents. So it depends in our practice, somewhere between 24 to 48 hours. And sometimes if you have extensive DVT and you also have an IVC, extension of the clot, or you have a May Turner and associated with pulmonary embolism, you may actually go up to 72 or 96 hours.
And what catheters do you use for thrombolysis? Fountain, McMurray?
There are very good dedicated casters, like casters and so many things, but they are all so costly. They are costing 20 to 40,000 rupees. So what I use is just 600 rupees catheter, which is actually even cheaper if you in other labs. It's just a multi-purpose 4 French catheter. You drill in holes every 1 centimeter and just inject saline and see that these holes are working, and they work very well. I've been using this technique both for DVTs and also for pulmonary embolism and arterial lysis for the last 25 years. And the results are as good, if not better, than
Thank you.
Dr. Aarti, you have a question? You have to unmute yourself.
It was an excellent beginning. First day was really great. And the lesson learned from the previous session is that no matter how many pointers we have towards some other disease or comorbidities, we must always rule out massive pulmonary embolism as an event as happened in 21-year-old.
Yeah,
congratulations.
And this is for coding patients, but even on the coronary side, it said we do a triple rule out test. So if you have a patient coming in with acute breathlessness or shock, and you do an ECG, and you find ECG changes of an acute MI or acute coronary syndrome, if you take them for a contrast CT, urgent CT scan, it actually rules out 3 things, or rules in 3 things. It rules out massive pulmonary embolism. It rules out or rules in a pneumothorax or an aortic dissection. So if you do this test, these are 3 things which are often missed. And if you're not sure, it is better to take this CT for urgent contrast CT in 5 minutes to get the diagnosis. And I am, Dr. Kanwar would remember we had a similar patient where we were thinking of something else and it came out to be a pulmonary embolism, and we actually lysed this patient and made a thrombectomy, and he did very well. It was one of Dr. Kanwar's patients.
Yeah, I can recall that patient, and it was a little confusion in the beginning, but eventually it was proved to be pulmonary embolism, and you did a great job in that also. I recall that patient, but it's been a long time, so it's been some time, so I can't recall the details.
Why I put this into the program is not only that VTE is a common syndrome which we see in our day-to-day practice, and what also we see is in the COVID era and pandemic now, VTE is one of the very common presentation, and if you miss out on this, we are going to be losing a lot of patients. This is a lesson which we learned from the Italian series, the Topsies, and also from the US series and the UK series in the Topsies. The patients were dying because of thrombotic complications rather than pneumonia and stuff. So this is all infective shocks. So this is something very important. And on the Sunday evening, first session is devoted to cardiovascular complications of COVID. In fact, we have 3 speakers. We have dedicatedly talking about cardiovascular manifestations. 2 of them are actually talking about thrombotic complications, and both of these speakers actually have published articles in the Lancet and in the Journal of Medicine. So welcome all of you to attend that session. It's a wonderful session on vascular manifestations of COVID by the original researchers. So if everything is no more questions, Dr. Arilan, Dr. Aarti, Dr. Kapil, I would take, and Dr. Devabrata Roy, I would take your permission to wind up today's session